there. My name is Dr. Sooki Hon with Atlanta Gastro and United Digestive, as well as Piedmont Hospital. I'm here to talk to you about new treatment options for PBC. What is on the horizon for our patients? So after a diagnosis of PBC, or primary biliary cholangitis, treatment should be initiated. For many years, patients were limited to treatment with ursodeoxycholic acid, or UDCA. UDCA is a hydrophilic bile acid, which has been shown to improve biochemical markers like alkaline phosphatase, delay histologic progression, and improve transfat-free survival for patients with PBC, particularly for those patients who are diagnosed and treated early in the course of their disease. The first-line treatment for PBC is UDCA at a dose of 13 to 15 milligrams per kilogram per day in divided doses. The use of PBC is generally well tolerated. There are some possible side effects like pruritus, nausea, and weight gain. However, the use of UDCA does not ameliorate any other symptoms of PBC like fatigue or itching. After 6 to 12 months of treatment, the efficacy of UDCA should be assessed. Part of the workup after diagnosis of PBC should have been an evaluation of the patient's baseline level of fibrosis or scarring in the liver. Patients with more advanced stages of fibrosis should have an earlier assessment of the efficacy of treatments, starting at 6 months instead of 12 months. Many current clinical trials do set the goal of biochemical response to reduce alkaline phosphatase levels to less than 1.67, the upper limit of normal. However, more recent work from the Global PBC Study Group suggests that there remains a risk for progression to liver-related complications and a need for transplants, even with very mild elevations in alkaline phosphatase levels over normal. As such, more hepatologists like myself are now advocating for normalization of alkaline phosphatase as the goal of treatment for patients with PBC. And so, if the alkaline phosphatase level remains elevated after 6 to 12 months of UDCA therapy, patients with PBC should be considered for second-line therapy. Up to 40% of patients are thought to be incomplete responders to UDCA, and 3 to 5% are intolerant of UDCA due to side effects. And for those patients, we now currently have the choice of 3 second-line agents, each with comparable high efficacy rates. Each of these 3 agents can be used as either adjunctive agents along with UDCA or as monotherapy. The first of these second-line agents to be approved was Obeticholic acid. It is an oral pill taken once a day, starting at 5 milligrams, with a goal to increase to a maximum dose of 10 milligrams a day. Obeticholic acid is an agonist of the trans-Lloyd X nuclear receptor that regulates bile acid transport, and also has been shown to have anti-fibrotic and anti-inflammatory properties. The side effects of pruritus with use of obeticholic acid could be alleviated for some by dose reduction. However, was severe enough to necessitate drug discontinuation in others. In addition, since coming on the market in 2016, they have been reported several cases of worsening liver function with the use of obeticholic acid, generally in patients with more advanced liver disease. There have also been cases of clinically significant liver injury as well, with patients without cirrhosis. As such, the FDA has recently placed restrictions on the use of obeticholic acid, advising frequent liver test monitoring with use. It does remain currently available for use in the market for patients with PBC without oral hypertensive complications, such as ascites or variceal bleeding. But excitingly for us, in 2024, there are 2 additional agents approved for second-line treatments for PBC. Elafibranor is an 80 milligram pill taken orally once a day. It is a PPAR dual alpha and delta agonist. PPAR activation is thought to reduce bile acid synthesis as well as reduce inflammation. Elafibranor was approved under accelerated approval based on results from the Elafibranor trial, where use of 80 milligrams of Elafibranor, with or without UDCA, didn't meet the study endpoint of biochemical response, with a reduction of alkaline phosphatase levels in 51% of patients in the treatment arm versus 4% in the placebo arm. Furthermore, 15% of the patients treated with Elafibranor were able to normalize their alkaline phosphatase levels at the end of the 52-week trial period, as opposed to none in the placebo group. There was a trend towards reduction of pruritus seen in the Elafibranor-treated patients, although the analysis did not reach statistical significance in this trial. Elafibranor was well tolerated, with mild side effects of nausea and diarrhea. There were a few cases of rhabdomyolysis that were reported, particularly on patients with statin therapy, and thus monitoring for myalgias is recommended. Patients should also be counseled that based on animal studies, Elafibranor may also have adverse effects on fetal and newborn development. Due to drug interactions, use of hormonal contraceptive is not recommended while on treatment with Elafibranor, and thus various methods of contraception is recommended. Our third agent is Seladelpar. Seladelpar is a PPAR delta agonist, available as a 10 milligram pill taken once a day orally. Like Elafibranor, Seladelpar is available for use under accelerated approval from the FDA for patients with PBC who do not have cirrhosis or who have well-compensated cirrhosis, who are intolerant to UDCA or who had an incomplete biochemical response. In the response trial, Seladelpar, 62% of patients treated with Seladelpar were able to achieve the study endpoint of biochemical response, as compared to 20% of patients on UDCA alone. Normalization of alkaline phosphatase levels was seen in 25% of patients, and the treatment arm versus no patients in the placebo arm. It's notable that on this trial, patients with a baseline moderate to severe level of pruritus did find that the use of Seladelpar resulted in a significant improvement in their pruritus as measured by the pruritus numerical rating scale. The most common side effect of use of Seladelpar in the trial was headache, abdominal pain, abdominal distension, and nausea, and were all rated at 1. On the horizon, there are many other agents under investigation for the treatment of PBC, which may help the biochemistry as well as side effects of the disease, and importantly, reduce the rate of progression to cirrhosis. Some of the clinical trials are looking at combination therapies, using agents with synergistic mechanisms of action. The future looks promising for patients with PBC due to earlier detection with increased awareness, as well as new treatment possibilities in our armamentarium. Thank you so much for your attention. For additional information, please visit the GAP website.